popularly known as typhoid fever. This is somehow embarrassing because they always relate this condition to hygiene, trying to say that once you get typhoid, then you have some issues with hygiene. Unfortunate. It's endemic in sub-Saharan Africa. Ghana, we are part. You go to South America, they are almost like us. And then Middle and East Asia. The whole thing is that once you get this condition, then it means there is a problem with you as you connect yourself to hygiene. You have issues with hygiene. It is caused by a bacteria called Salmonella typhi. And to a lesser extent, you have other species of the typhoid called paratyphi, which could be A, B, or C. But the main thing is Salmonella typhi. It is the main cause of this problem. As I said, it is very common in areas where you have poor sanitary conditions. And therefore, poor sanitary conditions is very common in many developing countries, simply because we fall short of standards when it comes to good and proper drinking water, hygiene issues, and even sanitation. We are always delivering waste around river bodies, which will go then downstream, somebody will take it. There are some guys that no matter what, give them first class WC, first class washroom, they will say no. They prefer sitting in the open area or in bushes where they can smoke their weed or cigarette. They want air to blow around their buttocks when they are sitting. They feel better that way. So if you give them golden bean washroom, they don't like it. This mindset will by all means contribute to the spread of this condition, because the mode of transmission is via oral fecal or through the urine, but most importantly, it is oral fecal. Oral fecal means you swallow somebody's feces, either through a contaminated water or food or any other source. So the moment you are diagnosed of typhoid, it means you have ingested somebody's feces. Typhoid is equal to injection of another person's feces. Now, for this condition to establish, there are several factors. So it is multifactorial that will lead to a successful establishment of typhoid. Some of them are agent related. The agent, I mean the typhoid bacteria itself. Or it could be host related, I mean the human host. It could also come from the environment and issues like the incubation period and the mode of transmission. So let's try and then look at some of these factors and see how they are related to typhoid fever. Now, the infectious agent itself. This is a gram-negative facultative error. It doesn't form spores. And the main guy is Salmonella typhi, as I said, or to a lesser extent, the paratyphi A, B, and then the C strains. This bacteria is highly motile. It can move around because it has flagella. The unfortunate thing is that it does best at 37 degrees Celsius. Unfortunately, for humans, our normal body temperature is around 37 degrees Celsius. And therefore, it makes our body conducive for them to proliferate, multiply, and establish the case of typhoid fever. For the bacteria, those that possess a special antigen called the VI antigen, it confers virulence. It's linked to increased pathogenicity. So if you are unlucky and you are infected with those with the VI antigen, then be sure that the clinical state will be very severe as compared to when you are infected with those without the VI antigen. In addition to the VI antigen, they also come into your body with additional 2 antigens that we may use to diagnose their presence in your body. One of the antigens is the O, or the somatic antigen. This is found on the body of the bacteria. It is less immunogenic, but very stable when it comes to temperature. The antigen that is found on the flagella is also called H antigen. And this is highly immunogenic. It can induce your immunity and cause a case of inflammation, but that is not thermostable. So these are the issues with the agents. So you see, the fact that it does well at 37 degrees Celsius, it's not surprising that the only form of reservoir where they can stay and come back and cause harm is in the human body, because our body temperature is very conducive for them. Now, when you get infected, you could be described as being a case or being a carrier. Even after treatment, you can still be described as being a carrier. Now, when do we say that there is a case of typhoid fever? So, as long as you test positive when we use stools or urine, then you are a case. It means that you are infectious. Then we have carriers. So carriers, they harbor the organism in their body, but only excrete them through either urine or feces over a period of 6 to 8 weeks. That is temporal carriers. Just a short time, then they only harbor. They don't exhibit the clinical signs and symptoms, but they are always excreting through their feces or urine this bacteria for a period of 6 to 8 weeks. Then for the so-called chronic carriers, they harbor these organisms, they excrete them through their feces or urine for at least a year. But whether you are a temporal or you are a chronic carrier, you yourself will not exhibit the signs and symptoms of typhoid fever. Whereas those who are described as being a case, they will exhibit the signs and symptoms of typhoid fever, almost similar to that of malaria. And therefore, if you have malaria and you are treating and it's not responding, some of the things that you may have to rule out may include typhoid fever. Now, where do they stay and therefore find their way into the human body? So, whoever has them in their body, be it a case or carriers, and they excrete, for example, their feces or urine, then it finds its way into the human host. For example, either through contamination of water, food, you go to the washroom, your fingers get contaminated with some of these things, your urine or feces, you don't wash it very well, then maybe you begin to bite your fingers or you lick your fingers. Or if flies like house flies settle on somebody who is a carrier, his feces, and then fly all the way back to your drink or your food, and you take them. Some of these are the links through which the bacteria will find its way into the human body. And of course, just like any other infectious agent, for them to establish a case of typhoid fever, the population is very, very important. And therefore, inoculum size, how much gets into your body and how fast they can multiply to hit a certain population that can help them establish the case of typhoid fever is also very important. But remember that you could still have some small population, but because of the presence of the VI antigen that confers virulence to them, they can still do very, very, very important harm to your body. Any queries? Any queries? So we are still on the agent. Vice Captain, any queries?
None, please.
All right. So now, we are saying that through these sources, the bacteria can get into your body. They need enough population to do that. Fine. Plus the virulent factors. Already, your body's temperature is helping them because they do well at 37 degrees Celsius. So now, how are they going to establish themselves and possibly cause harm to your body? Let's try and then understand it. So it always begins from you ingesting a contaminated food or water or licking your fingers or house flies, bringing them, then you eat. Then they get into your GIT. The salmonella gets into your GIT. Once they get into your GIT, the next step is for them to try and invade your small intestines. So they invade your small intestines. The moment they enter, monocytes over there will engulf them and then introduce them into your blood stream. This is referred to as the initial bacteremia. So straight from food source or whatever source into your GIT, they have the means to penetrate your small intestines, where your defense mechanism, for example, the monocytes within the PS patches, phagocytize them only to introduce them into the bloodstream. Their presence in the bloodstream, we call it initial bacteremia. Of course, the blood circulates, and therefore, once they are within the blood, they are also going to be what? Circulated. So the blood will carry them around the body. And when they get into tissues or organs like the liver, the spleen, and the bone marrow, remember, these are the reticuloendothelial cells. They are sequestered within these organs. What are they doing there? They multiply within these tissues or organs to gain more numbers. So in the liver, in the spleen, in the bone marrow, once the blood sends them there, they stay there for a while, multiply in numbers. And once they've attained huge numbers, they move back into the bloodstream. That is the second bacteremia. Remember the initial bacteremia. Now they move from the blood, they got hidden within these tissues or organs, multiplied, and now they are back. So they're almost just like malaria. You are inoculated, you get the sporocytes into the blood. The numbers are few. They are smart. So they get into your liver, multiply there, and then come back again into the blood. So initial bacteremia, then second bacteremia. Now that they are in your blood, again in high numbers, then they have the numbers to invade multiple organs. So then they can invade organs like your gallbladder, your biliary system, even your lymphatic tissues of the bowel. And even over there, they multiply again. So they are just multiplying. Until you do any intervention, they are just doing their own thing. So those that will enter these areas, your biliary system and then the lymphatic tissues of the bowel, some of them will pass back into the intestines, so the intestinal tract. And of course, they can even form part of your feces from there on. An advantage is that with this, when you test the feces for the presence of the Salmonella typhi, because they come back again into the intestines and then join the feces, some of them, you detect them in the feces. So by the time that you can detect Salmonella typhi in the feces, it means that they've gone through everywhere that they want to go, because the last stage is coming back into the feces. Now, what happens? Before they can enter your small bowels to cause the initial bacteremia, they are aided by special means. So that is mediated by the cystic fibrosis transmembrane conductance regulator. These are microfood cells. It is through these cells that the moment you ingest them through any food or drink, they pass through and enter your lining of the bowel. Note, once they are within the blood, we said they will be circulated to the reticuloendothelial system, including the liver, the spleen, and bone marrow, where they multiply. Interestingly, their replication, that is the multiplication within these organs, is the thing that is responsible for the clinical signs and symptoms, including prostration, generalized sepsis, and the enlargement of the liver and the spleen, hepatosplenomegaly. These are typical signs and symptoms of typhoid fever, and it is because they enter these reticuloendothelial organs, i.e., the spleen, the liver, the bone marrow. Of course, when they multiply, they can cause sepsis, they can cause inflammation. You become very weak, there will be prostration, and of course, the liver and the spleen could even become enlarged, typical of typhoid fever. Any queries? Any queries? So remember the microfood cells as the means through which they penetrate your small intestines. The clinical signs and symptoms, though they are in your body, may not occur until they invade your reticuloendothelial system, begins to multiply, giving rise to prostrations and generalized sepsis. Of course, in the liver, in the spleen, enlargement may occur, and therefore splenomegaly, hepatomegaly. Any queries? Any queries? Class captain.
None, please.
All right. So now, for the host factors, the agent factors, how about the host? Do we have any means to defend ourselves or to even help them, for them to establish themselves? Age is an issue here related to hygiene in some way. This category of individuals, 5 to 19 years, issues with hygiene. Anything at all they are eating. Their food will fall on the ground, no way. They won't allow it to go. they will pick it and eat. Even if it falls in gutters, they will pick it and wash it and eat. Mangoes will fall in gutters. You will pick them, wash it, and eat. 5 to 19 years is therefore a risk factor for the condition. Sex, here again, my own people, males, we are more at risk when it comes to infections, probably due to hygiene again. But the thing is, when females, they get it, they are likely to become carriers. So carrier rate is associated with female sex as compared to male sex. But when it comes to getting the condition itself, obviously, hygiene issues, females are better than us. Then the individual's own immunity. The individual's own immunity. For example, one of the first line of defense in the GIT is your pH. If you have high acidic pH, then the moment the food or the drink is ingested, salmonella will be killed by this acid. If you are on antacids, PPIs, H2 receptor antagonists, or any other agent or condition that reduces your GI pH, then you become vulnerable because the organisms will not be killed by any acid. The acid is very weak, and therefore you'll be predisposed to getting this condition. So you can even eat from the same bowl with a food that has been contaminated with typhoid with another person. But because you have a very good pH in your GIT, you won't get the condition. But the other guy who has a diluted pH or conditions like a chlorhydria, where there is almost non-acid secretion, then there could be a problem. Again, immunity, if you have immunity against the infection, it could be by natural immunity from an infection or maybe from a vaccine. Then, of course, you already have antibodies against the bacteria, and therefore you can fight it the moment they get into your body. So you can get antibodies production either by natural cause, when you have ever had the infection before, or you have taken the typhoid vaccine. So that can help you protect yourself. So these are some of the factors that the host can bring on board. Some are protective, some even will aid the bacteria to establish itself. So young age, 5 to 19, negative. Male sex, negative. If you have a diluted gastric pH, negative. We need high acidity. If you have antibodies, positive. If you don't have antibodies, negative. Any queries, class captain?
No, please.
All right. So depending on where you live, where you stay, that could also be an advantage or a disadvantage in a way. Because I've been saying that this condition is regarded as what? A hygiene issue. So the condition is regarded as a measure of an index of general sanitation in a country. So in a country where the incidence of typhoid fever is high, it is shameful. It means that you guys, when it comes to hygiene issues, no. You are nowhere near. Sanitation is poor. So once you get outbreaks of typhoid, then it's a bad sign. Of course, there is an increase in the incidence rate during the rainy season, because that is where you have a lot of water bodies filling and spreading across, carrying feces from carriers, urine from carriers, all the possible sources. between July and September, the rainy season. In Ghana, it can even start from June, July, August, September, where it rains. You have a lot of these feces being washed away into river bodies only for individuals to take them. Unfortunately, the bacteria is stubborn. It can survive in just water bodies without any other nutrient. It can survive there for at least 2 to 7 days. So that if you go and drink that water, you could be in trouble. The only bad thing for the bacteria is that it doesn't multiply. It stays dormant in just water bodies. But if you have soil that contains feces, sewage, very good for them. They can stay in there for about 35 to 70 days. In ice creams, they can stay in there for over a month. Food, depending on the type, any other food, depending on the type, they can stay, survive, and multiply for several days. In milk, that is where they like. They grow rapidly. And the interesting thing is that you go there and the taste of the milk is just on point. It won't change the taste for it to even prompt you that this milk is not tasting nice. Something bad is happening. So you are not taking it. They'll be multiplying millions, thousands, but the milk taste will be nice, just on point. If you are not lucky, it may even taste better than the one that is not contaminated, so that you drink. That is the only way they survive. The human host is their only reservoir. Else, they will go into extinction. So they are doing strategies to survive. So they make sure that they multiply in the milk. They won't change the color of the milk. They won't change the taste. So you go and take. Once you take it, they are there. Then they start invading your bowel and then they cause problems. More environmental issues. You see where we grew our lettuce, cabbage, for example, those in KNUST, those river bodies around Tech Police Station and those areas. Those river bodies full of human feces. So that is the type of water that they use. They always sprinkle on it, like Roman Father blessing the congregation. You go and buy, you think you are eating lettuce, salad. So you are doing DASH diet. Eat more vegetables and fruits. Remember, depending on the source, you'll be eating a lot of typhoid fever. Carrots, where do we grow them? What kind of water do we use? So these are all issues. Vegetables that we grow near areas where there is what? Sewage. The soil is rich. So those vegetables and fruits, they do better. Open area defecation and urination. That one is boys, typical of boys. We are always doing that. It's not easy for ladies to do that. Boys, anywhere, we just pull out our penis, start urinating. We can do it anywhere, very bad. Then low personal hygiene. And of course, if you are ignorant when it comes to health-related matters, all these could contribute as part of the environmental and social factors in relation to typhoid. Incubation. So from the time that you get the bacteria in you till the time that they get into the reticuloendothelial system, start multiplying to cause sepsis, and for example, hepatosplenomegaly, it takes on the average 10 to 14. But depending on the virulence and the infective dose, you could get it, the signs and symptoms, as early as 3 days or later by 3 weeks' time. So you can get it between 3 to 21 days, depending on some of these factors, the virulence, the infective dose. But on the average, most people will exhibit signs and symptoms within 10 to 14 days. As usual, the mode of transmission is you eating somebody's feces, oral fecal, or you eating somebody's urine. You drink somebody's urine, not direct eating feces or direct drinking of urine. But these sources could contaminate potential foodstuff like your carrot, your lettuce, your cabbage. Most importantly, the ones that we eat them raw and you don't prepare them well. You just take carrot, you begin to chew. Salmonella typhi may be around. Or directly through your hands that has been soiled with these feces and urine. Then you try to lick your fingers or you bite your fingernails. Or you know, your hands or your fingers have been contaminated. Or through an indirect, as I've been saying, contaminated foodstuff, water, or what have you, then you get. Remember, they survive in these sources. All of this will contribute to the transmission. Now, if you get this infection between roughly the 10 to 14 days, what are some of the problems that an individual may suffer? Key thing that is almost always available, almost always present, is the so-called salmonella. That is gastritis, gastroenteritis. It is the most frequent clinical manifestation. Of course, since it's an infection, sepsis coming in, you may get hyperparaxia, and hence the name Enteric Fever. Of course, you get septicemia, sepsis that will lead to septicemia. And you could get widespread complications from the sepsis, hence metastatic lesions. You can get multi-organ problems. So it doesn't always stay. It's not limited to the blood nor the reticuloendothelial organs. You can get even CNS problems. You can get pulmonary problems. You can get bone problems, kidney problems, what have you. That is how serious this condition is. Hematological issues. Anything at all, typhoid can give you. It's just like malaria that can give you complications. It can present even as diarrhea. Anything at all can happen in typhoid fever. Any queries? Any queries? First Captain.
None, please.
All right. So now, the natural cause of this illness. If I say the natural cause, I mean how the disease begins and it progresses till it sends you to your grave. That is, if you fail to do any appropriate intervention. It normally takes a 4-week course. And as I've been saying, it is the Salmonella typhi that is more dangerous. The S paratyphi, be it A, B, or C, they cause the mild type. And of course, it is also the Salmonella typhi that will do most of the infections. The ratio is 10:1. So if you have 11 cases, 10 out of them, you will isolate Salmonella typhi. And then the one will be the other species, the paratyphi A, B, or C. But the clinical cause of the condition from the beginning till the end, if not intervened, will normally take a 4-week course. The general signs and symptoms, almost just like malaria, confidence trickster. Anything at all can happen, then you'll be treating another 10. Meanwhile, it is typhoid that is doing all those problems. You get fever, obviously is an infection. You lose appetite, just like malaria, anorexia, malaria. have headache, malaise, you cough, sore throat. You can get constipation or diarrhea. All these signs are present as well when it comes to malaria. Now, the 4-week period. What are some of the likely events that will occur on weekly basis from week 1 through week 2 to week 4? What are some of the likely issues? So normally in black, you won't see the rose spots. You may not see it. It's not because of our color. But in white, as part of the inflammatory response, they develop this kind of spot that appears pinkish or reddish like the rose flower. You see it dominant in their body. Then as part of the extreme toxemia, sepsis sets in that may lead to bradycardia. And of course, they can also get dicrotic pulses. This is as a result of this additional pulse that you feel caused by the carotid artery. Dicrotic pulse is very common with conditions that result in cardiac output. So in the first week, this may be the signs and symptoms. Of course, since it is progressing, things becomes worse. So the patient becomes lethargic. The intermittent fever now becomes persistent. Then the abdominal issues begins to set in. Remember, 2 weeks is 14 days. So the thing has by now spread from all the endothelial, the reticuloendothelial system back into the plasma, and it's even invading other areas like the gallbladder and all those areas. So you have persistent fever, abdominal issues, GI distensions. Then splenomegaly, hepatomegaly may all set in within the second week. Still no treatment because you are repeating, for example, your ACT. You think it's malaria, or you are taking some antibiotics that are not active against Salmonella typhi. Then you tip into the third week, which could be dangerous. Because by the third week, the toxemia could be so intense that your body may not be able to accommodate. By that time, since anorexia started in week 1, and maybe some diarrhea or something has also started way back, the person will be seen to have lost weight. The fever is still there. Then now we may even have CNS abnormalities. So the person may suffer from delirium, agitated or very calm, sedated. This is what we call the typhoid state or typhoid psychosis. The GI issues will be more pronounced. Splenomegaly, hepatomegaly, so pronounced abdominal distension. In fact, around this time, as part of the GI issues, the person may bring out some poor or bad smelling feces. That is normally referred to as the pear soup diarrhea. And there will be extreme weakness, weak pulses. As a response of the sympathetic system, there could be tachycardia. Pulmonary issues may set in, so crackles may develop. In fact, around this time, if you are not lucky, it is the third week that you may lose the patient because there is excessive toxemia. The person is overwhelmed. High inflammatory conditions, including myocarditis, pericarditis, issues like intestinal perforations. All these issues may happen in the third weekend. If the person would die, normally it is the third week. But in case the person doesn't die and survives and move to the fourth week, apart from the GI signs and symptoms, all the other problems may subside. So the CNS issues, the cardiac issues, and whatever. But the GI problems of diarrhea, splenomegaly, hepatomegaly, perforations, and all those things may be there. But note that if you don't intervene, normally it is the third week that the patient may go. If you tip into the fourth week, the extra GI problems may subside, but the GI problems will stay with you. Probably that is what is going to kill you. But in the third week, a combination of a lot of issues, multi-organ dysfunctions, will contribute to your death. Any queries? Class captain.
None, please.
All right. And so what are the common complications? Because we said that you can get multi-organ dysfunction. You can get metastatic lesions. So the GIT, obviously, we've mentioned intestinal hemorrhage. If severe, it can lead to perforations. You have a lot of individuals with even common peptic ulcer leading to perforations. This infection is dangerous. It can cause perforations in roughly 3 to 4 of the individuals who are admitted in the hospital. Hepatobiliary problems, cholangitis, cholecystitis, pancreatitis. All these can happen. You can even get acute renal failure with the hepatomegaly. So kind of renal issue. You can get toxic myocardial inflammation of the myocardium that may present with tachycardia, but weak pulses with abnormal heart sounds. Hypotension may set in. You do ECG, you are going to get abnormalities. Pericardium, that is the membrane surrounding the heart, could also be inflamed. So pericarditis can set in. This can lead to torsade de pointes, one of the arrhythmias that can lead to death. Typhoid is very dangerous. Neuropsychiatric issues, remember we mentioned typhoid psychosis. So you could get toxic confusion states. You could even suffer from convulsions. It can even spread into the meninges and cause meningitis. Even the brain itself could also be affected, get inflamed. So you can get inflammation of the brain. Then, of course, the typical psychotic issues, schizophrenia or mania, and at times, the other side, depression. Typhoid can bring any of these problems. Hematological issues, subclinical disseminated intravascular coagulations. So you are going to have possibly coagulopathies. Maybe it may not manifest as bleeding and hence subclinical, but there could still be problems with inadequate clotting factors. Of course, hemolytic uremic syndrome, not common. Hemolysis can also occur. Genital urinary problems may also present. So glomerular nephritis. The kidneys can get infected with the typhoid bacteria. You could get nephritis, that is inflammation. So anything at all is possible with typhoid fever. All the way to bones, musculoskeletal. Remember, they go into the bone marrow as part of the reticuloendothelial system. So you can get polymyositis. CNS, we've mentioned it already. So these are the common complications that normally occurs in typhoid. And these are the ones that may harm you. How do you investigate, apart from the signs and symptoms and these complications? How do you investigate and confirm the presence of typhoid fever? So we can do microbiology. We are going to test for culture and sensitivity. So we pick samples and do culture and sensitivity. Or we do serology, trying to identify some of the antigens and antibodies against the bacteria. Then there are new innovations that we can also utilize to promptly identify the presence of these bacteria, because the newer ones, they have high sensitivity with high specificity. against typhoid. So in terms of microbiology, it's all about culture to isolate and possibly sensitivity test. So samples may include blood culture. Blood culture, you need to take at least 15 mils of the blood. One thing that patients always suffer from diagnosis is the possibility of anemia. At times, the kind of blood samples that they would take almost every day for examinations alone can lead you to anemia. That is one of the key causes of anemia in the ICU. We are always picking blood samples for some tests, and therefore that alone can lead you to anemia. Blood is very sensitive. Of course, they go in there, initial bacteremia and then second bacteremia. And therefore, you can easily detect them in the 60 to 80% sensitivity. Remember, they come back into the GI to join the feces. That one is 30%. Then they also go into the bone marrow as part of the what? Reticuloendothelial sequestrations. And therefore, they say bone marrow is the most sensitive sample. But over here, nobody in his right sense will go and take bone marrow aspirate or sample because the person wants to isolate typhoid. No, we don't do that. But it is the most sensitive source that you can use, 80 to 95%. Of course, you can also use urine. You can also use remember, liver. So these are all possible samples that we can use. But normally, it is blood culture or feces, or the two together that we use to identify or try to isolate the bacteria microbiologically. So normally, if you be successful by using blood cultures, depending on the cause of the condition, that 4-week period, your chances of isolating the bacteria increases or decreases from week 1 up to the week 4. So week 1, you have about 90% chance of isolating, and it decreases all the way to 25% to week 4, meaning by week 4, the organisms or the bacteria, they have moved from the blood into those organs that you have the complications, the brain, the heart, the kidneys, the intestines, the what have you. Then you have few in the blood. So normally, if you be successful by using blood culture, it is within the first 2 weeks where you have about 90%, 75% chance of isolating Salmonella typhi from blood cultures. Serology, you are testing for antibodies, antigens, antibody-antigen reactions. One of them is the Wilder test. The full name is Felix Wilder test. So this one, you measure agglutinating antibodies. Once any foreigner comes into your body tries to what? Produce antibodies against the presenting antigens from the foreigner. And therefore, you produce antibodies, which through the test, there will be antigen-antibody reactions, the so-called agglutinations. And therefore, when this happens, then we say that, oh, the Wilder test is positive or negative. Then we try to also measure the extent of the infection. Is it clinically significant or not? So normally, there is clinical significance, but this depends on the lab. They may have different references. So depending on the lab that you are using, the reagent that they are using, they have their own references. So you compare the patient own to that lab's references. So for example, for the O antigen, some labs, they have a reference of 1/100 dilutions. Others will have, for example, 1/60 before they can say that clinically the infection is significant and therefore it demands treatment. With the H antigen that we said, it is more sensitive, it is more immunogenic. Then you can even use higher dilutions. And because they are highly immunogenic, you can still detect them. So for the H antigen that is found on the flagella, we use higher dilutions, like 1/200 or 1/320. And from this point, if you still have agglutinations, then we say that it is significant. So, for example, if you use the test tube method without test, these are all dilutions. So maybe you have taken the blood sample, you dilute it 20 times. You take this one, you dilute it twice again, so you get 1/40. You dilute this one twice, you get one. So as you dilute it, then it means that the amount of the agent in there will be reducing. So if you still detect the bacteria or a reaction in a high diluted solution, then it means that if you are to pick the initial one, then you have almost high levels of the bacteria in there. That is why they give cutoff points for this per dilution. So for example, in this test, you can see that this concentrated 1/20, obviously there is agglutination after the reagent was added to the blood. 140, there is that. 1/80, there is that. The highest dilution that we had agglutination was 1/60 because we don't have it in the 1/320. And therefore, you compare this to the reference. And if 1/160 is the point where you say that clinically it is significant, then fine, you conclude that, oh, okay, clinically, maybe the O antigen or the H antigen test is significant because per our references, if agglutination occurs in the dilution that is 1/60, then it is clinically significant. As for the test tube method, you add a very low volume of your sample, that is 20 microliters, to the test reagent. And with this, since it is very low volume, we don't expect to see any significant reaction. But if with this low volume, you are still able to get a reaction, that is agglutination, then it means that if you are to pick high volumes, that would be worse. And therefore, low volumes like 20 microliters still showing reaction means that clinically there is significant infection. That is how they do the radar test. And they always report the O antigen test that is on the body, less pathogenic as compared to the H antigen that is on the flagella, more pathogenic, and it's able to stimulate your immunity better. So with the H antigen, you are producing more and more antibodies than the O antigen. And hence with the H antigen, you use higher dilutions than the O antigen test. And per the reference value, you get agglutinations or reactions in what they are saying that is their reference point. Then you say that clinically the infection is significant and therefore it demands treatment. Any question? So this is the radar test. Any question? Class captain?
No question.
All right. So in most cases, they say that the radar test is not that sensitive because normally it will be sensitive in about 40 to 60% of the patients. Almost about 40% of the patients, you get either false positive or false negative. What are some of the contributory factors when it comes to the radar test that will make somebody test or give us false positive results or false negative results? So since it is an antibody antigen test, somebody might have gone for the vaccine and therefore has enough antibodies. So with such an individual with immunity, high levels of typhoid, well, if you go for the radar test, there will be agglutination. That doesn't mean that the person has typhoid, but he has the antibodies through vaccination or maybe an infection that was there some way back and the person has gained antibodies from the infection. Or somebody could be a carrier, and the mere fact that the person is a healthy carrier, then of course there will be antibodies. Or it could even be an infection from different strains of salmonella. That is not the typhoid type or the paratyphoid type, but different forms of salmonella where the person will develop similar antibodies to that salmonella strain. And therefore, if you use antibody antigen test, there will still be agglutination because salmonella, they are similar in terms of genus. And therefore, the antibodies that the person will develop against a different species of salmonella will be almost the same as the one from paratyphi or typhi, and there will be false positive results. False negative, in situations where maybe a day or two, then you collect the blood sample, then you do the test. You don't have enough of the antibodies. It takes time for antibodies to be produced. And therefore, in this case, the person may have the infection, but since you did the test too early, the person might have not produced enough antibodies by that time, and therefore it will give you a false negative result. If somebody has the infection and then go and take antibiotics, this may reduce the load of the bacteria and therefore its ability to provoke the person's immunity for the person to develop enough antibodies. And this may result in a false negative results. And there are some individuals living that who just do not produce antibodies against salmonella, typhi, or paratyphi. They just don't. They don't have any problem. But when they get the infection, their immune system doesn't produce antibodies against. We have about 5 to 10% of the population who has this issue. They have the infection, but they can't produce. Not that they are immunocompromised. They are immunocompetent, all right, but they just don't produce antibody. Then those who are immunocompromised, if you are immunocompromised, how do you produce antibodies to fight? So they get the infection and they can't produce. So you do the serology test. Since there is no antibodies, it will give you negative results. Meanwhile, the infection is there. These are some of the instances where individuals may give you false positive or false negative results. Are we okay? Then the newer innovations, the current ones that can do the test within days, within hours, with high precision, high sensitivity, high specificity. So we have the IDL 2-base test elsewhere in Europe, US, testing for immunoglobulins, antibodies. That can give you the results within minutes. Then we have the typhoid test that deals with immunoglobulins again, immunoglobulin G and immunoglobulin M. That one gives you the results within an hour. High specificity and sensitivity. Sensitivity of 95% and specificity of 75%. Then we have the typhoid M, even better, with 90% sensitivity and 93% specificity. There is even typhoid rapid test, immunoglobulin dipstick nowadays, and even the polymerase chain reaction test. All of these are newer innovations that can give you better results than the Whether tests. And I believe most of the labs here may have one or two, at least the PCRs here. Some of the immunoglobulin tests that can give the results in minutes are here. But most people still do the Whether test with all these problems, high risk of false positive and false negative results. Now, how do we control? We won't start the treatment today. So next week when we come, we will start, and when we are done, we continue with another topic. But how do we control typhoid fever? How do we control? We need to control reservoirs, and human beings are the only reservoirs. Those with a case, you need to control them by treating them. Those who are carriers, are there any interventions to clear the bacteria from their body? So we are going to control reservoirs. Then since it's a case of hygiene, we need to control our sanitation. Then possibly immunization so that we prepare ourselves. So that even if we get in contact with a potential contaminated agent, since we have enough antibodies, we will be protected. So we are going to do, Class Captain, do we stop or we continue? Class Captain, we have about 10 minutes to 12. What do you suggest? Hello? Hello?
Hello, sir.
What do you suggest? Do we stop here, continue? Because we have just about 10 minutes to go. So I suggest we end today's class here. Then next week,
Yes.
when we come, we have some few slides to go. We will finish and then start another infectious topic, possibly maybe meningitis, and hope we can finish that one too. So next week, when we can first 15, 20 minutes, we can finish this and then tackle meningitis and hopefully we finish. Any queries?
No, please.
Any? All right. Okay. So then, Class Captain, any announcement?
No, please.
All right. Then catch you same time next week. Please note the slide number, control of typhoid. Okay.
Yes, please.
So
Okay.
we'll begin from here. All right.
Okay.
Have a nice weekend.
Thank you.